My name's Matt Siuba. I'm one of the staff at the Cleveland Clinic working alongside Eduardo and Rob in terms of doing some ventilator education. Today's SEVA VentRounds, we're going to talk about the exhalation phase of mechanical ventilation. For our disclosures, sorry, I just have to clear this co-host thing off my screen.
Don't forget to record it, Matt.
Yeah, I think it's being recorded, right?
Yeah, I started the recording.
That's what I thought. Okay.
I'm filling in for Dave Wolfley.
Okay, gotcha. Excellent. Thanks a lot. All right, so we'll discuss a number of modes and ventilators, different brands. We don't endorse anything in particular. All the views expressed here are our own and not the clinic's. Eduardo and Rob's disclosures are listed there. They don't have any impact on anything we'll discuss today, and I have no disclosures myself. In general, just try to keep your microphones muted. If you have something you want to say, put it in the chat feature and we'll address it as we come through. Employees from the clinic will get CME for today, and that information will be at the end of the presentation. So to start, a couple things that I want to review is just talking about what normal exhalation looks like, because everything that we do in mechanical ventilation education depends on what's normal, so we can tell what's the abnormal. So in this waveform here, you can see, exhalation is normally a passive process and it has exponential decay to the baseline. So that's kind of what you're seeing here. If we introduce PMUS into this, then you'll actually start to see flow moving away from the baseline. And then so it'll pull it away from the normal phase here. There will also be changes based on, There'll also be changes based on the resistive and elastic components of the breath. I'm going to see if I can get my pointer working so I can show that. All right, looks like it is working. Okay, so the normal we already saw is kind of passive and fills that way. If you think about having a higher resistive load to the breath, let's say somebody with obstructive process going on, you would expect that the time for the lung to empty passively naturally would take longer. This would have a longer time constant. So if you remember the time constant formula, it's resistance times compliance. So the way that to think about whether something is a problem or not is just based on what direction it's prolonged in. So if you have a longer time constant, you could either have a higher resistance or a higher compliance. Usually high compliance is not a problem, so we think this is probably a resistive issue. And what that will look like is a longer time to return to baseline, a longer time to empty. So something with a higher resistive load might look like this waveform down here. And it may not even return to baseline depending on how quickly the next breath is initiated. In converse, if you had a short time constant, again, we wouldn't think that a low resistance would be a problem. We think a low compliance or a high elastance would be a problem. And the way that I think about this is the lung kind of snaps shut a little bit faster because it has a higher elastic load to it. So that waveform will come a little bit quicker up to baseline and probably return to it much faster. Rob, anything you want to add?
No, we're seeing your preview slides. Can you switch to like a full presenter mode?
Oh, you're not seeing. Okay.
You see them?
How's
there
that?
you go. That's it.
Okay.
Very good.
All right. Excellent. So with that in mind, we'll head to the first case. So we'll go through the normal process here, the tag, the load, any discordances. If Daryl can start the poll, we'll do the poll, and then we'll give you about 2.5 minutes to answer, and we'll come back.
That is grayed out on my options. I'm not sure if someone already opened it, but it doesn't give me the option to open the poll question. Let me go ahead and give you the host, Matt, and see if that'll let you. I'll make you the host.
Okay.
And you might be able to get that open.
I'm not seeing it.
It's under file and it says open poll question, but mine was grayed out, so I'm not sure how you
Hmm.
guys do that part. This is my first time. I don't see it as an option. It has to be set up, I guess. I don't know. Let me just see if I can change it. If
It's not critical. We only have 25 people anyways. We might as well
I was
just
Yeah.
gonna say, I
proceed.
might be able to change it if I take back the host and find out how to activate that while it's
Okay.
live. So I'll work on that.
Okay. Well, we can probably go ahead and see if one of the fellows wants to volunteer and walk us through this one.
Doesn't look like we have a whole lot of fellows today.
That could be a problem.
Hey, Morgan, are
Let
you
me
out there?
let me see if I can rearrange my screens a little bit to make it easier for me to see what's going on.
Hey Rob, want me to take a gander at this?
Sure, go for it.
All right.
Sorry, I took it off
Um,
the screen. I got to get it back.
all right. I'll wait for you.
This is Ibrahim.
You should have really removed the tag up top.
Well, that also is a clue, right?
Yeah.
You can't really tell otherwise.
Yeah, right.
So I'm gonna go with ignoring the tag, just looking at the waveform. Since the pressure waveform is more square, and it seems that flow is more of a passive participant in this. This looks like pressure control. And since the I times of, well, really the three breaths that I can see are similar, I don't have any reason to believe this is IMV, so this is PCCMV. And since I know this is PRVC on the servo, this is PCCMV adaptive. So
Correct.
Right.
this is me cheating here. So
That's all right.
for the load, just kind of looking at the waveforms, flow waveforms mostly. During inspiration, you can see that there's really slow decay of that inspiratory waveform, and that's even more pronounced during expiration, where it's not a rapid snapback. So this looks like a more resistive load. Although towards the last breath there, I'm not sure if there's any PMUSC activating and causing a forced exhalation. I don't know if I can actually point to what here. Let me see if I can show you what I'm talking about.
Sure, I just gave you permission to
This.
annotate it. Yeah.
The question that I have is this a forced exhalation kind of stacked onto what was happening before? So, but it's mostly a resistive load.
Gotcha.
I'm just gonna do. Oh,
So
should I
let's see
just
if I
go
can.
to patient ventilator discordance?
Yep.
Yeah.
Sure. All right. Now, the trigger, again, this is I don't see a massive deflection downwards in pressure to suggest a delayed trigger. So this looks like a normal trigger to me. And I don't see a whole lot of fluctuations in the pressure waveform to suggest any missed ones or failed triggers. So I'm going to go with normal trigger.
Is this pressure or flow trigger?
I would honestly say this is a flow trigger.
Yeah, you can see a little white segment on the green that the ventilator is indicating to you that that was the signal used to trigger with. Yep.
No, yeah, because I don't really see much of a downward
No,
deflection in pressure to suggest that it's a pressure trigger.
no, right. Well, like I said, if it was a pressure trigger, there'd be white on the yellow. The
Yeah, it
white
would be
is
right
not
here.
there on the green.
I must say I've never seen that because I never do pressure triggers.
Yeah.
I'm a neonatologist for people on this call, so we never do pressure
Fair.
triggers.
Yeah, you probably don't
Um,
want to make it harder for your patients to trigger, generally speaking, I'm guessing.
yeah, no, flow triggers is what we normally do. Now, ooh, this is where I'm gonna get messy about inspiration. I don't know that I would. That one I really don't know what to say about. Whether there's work shifting. I mean, most of the work looks like it's being done by the ventilator on the patient rather than the other way around. I don't see massive deflections to suggest the patient providing work on the ventilator, but I don't know what to say about that. From a cycle perspective, you could argue, given the slow decline due to the increased airway resistance, that this is relatively early cycling. But I think that's a matter of perspective at this point. Expiration, again, the purple part looks like the patient might be doing some expiratory work on the vent at that point, trying to force some exhalation there. So there may be some expiratory work being done. I don't know.
Very
Thoughts?
good. Very good. Very
Yeah.
good. What do you say, Matt? What do you think?
Yeah, so I think overall I got the important stuff handled pretty well. I just kind of want to kind of walk through everything again. I think the most important thing, since we're talking about expiratory work today, is I think if this person is doing I'm sorry, we're talking about expiratory waveforms. This person is doing expiratory work. You can see because it's the waveform bows down like this. If this was a passive breath, even if it had an elevated resistive load but was passive. Sorry, I'm trying to move this other annotation. There we go. It would still have the normal kind of shape to it. It just wouldn't return to baseline as fast as you would think. So this person is forcefully exhaling, which I think is the key patient ventilator interaction here. There is some work being done in inspiration as well, because this, in a pressure controlled breath, a passive patient would have exponential decay of the breath. It's usually a little bit flatter in PCCMBA than it is in PCCMBS, but it would still be there. So the fact that it's actually moved in this direction suggests that the patient is doing some work. Another way you can tell it's not, I think you're right to say it's not that much work because, in PCCMBA, we'd usually see the pressure waveform starting to get deflected downwards if the patient was doing an untoward amount of work. So I think this is kind of probably an acceptable amount of inspiratory work. The reason for the expiratory work then becomes the question, and with the limited information here, it'll be difficult for us to answer it. Sometimes that is an issue that a airway or a ET tube resistance is what's causing the person to have to do the expiratory work. And it looks like you're raising your hand, so I want to let you speak up.
So why wouldn't this be increased airway resistance during inspiration causing a very slow decay?
Well, my answer to that would be two things. One, if it was a high resistance, you wouldn't get a very high peak flow. The peak flow is relatively high, particularly relative to the peak expiratory flow, which is another clue. And the other thing is just how often do you see a patient that's making a fairly significant expiratory effort but no inspiratory effort? Patients like this are hypoxic or they're anxious or whatever, and so they're breathing in and out, in and out. So it's just like so I guess it's sort of common clinical observation. That's the way I would think of it.
Yeah, I agree. And Ariel mentioned there's some air trapping. There might be. It's really hard to say when somebody has active exhalation. It's harder
Yeah, you
to
can't
grade
tell.
that. Yeah.
And it's hard to say anything about mechanics when the waveform is so distorted by the PMUS.
Absolutely. Any other comments from the audience or from Rob?
I think Ibrahim mentioned the early cycle, and I would agree with that because look at the peak inspiratory flow is relatively high compared to the peak expiratory flow. So I think this patient's still breathing in when the ventilator's shutting off, clipping off that peak expiratory flow. And then he says, oh, time to exhale. And so he forcefully exhales. So there's a lot of things going on here, but overall, that's a very good assessment.
Yes. Sherry asked, is there a failed trigger at the before the last breath? I think probably. So right
Good-
here,
good
I think
point.
is what she's talking
Yep.
about.
Yep,
Yeah, I'd say
absolutely.
so.
Yep.
Yeah.
Yep.
And then Dilip asks, Rob, is the time controller something that can be turned off?
The time controller.
Yeah, I'm not sure
The
what that means.
the deflection drop that happens in the servo ventilators right at the beginning of exhalation, the time gain controller thing, you know, the one that causes the notch at the end of inspiration.
Oh, that little notch right there that Matt just circled in yellow, that is just a ringing. That's just noise in the pressure
That's
signal.
artifact.
It's just an artifact. There's no setting associated with that happening. I'm still not sure what you mean by time control. If you mean pause time?
No. Wasn't there a feature on servo that's supposed to make exhalation easier? What was it? The time gain controller or something like that they used to call it?
Oh, I'm not sure that that's true on this ventilator. Some ventilators do drop. If you're talking about dropping the airway pressure momentarily below baseline to facilitate exhalation,
Yeah.
home care ventilators do that. You know, BiPAP machines do that. I don't think this
Okay.
ventilator does that. And that's not documented in the manual, at least as far as I know.
Mm-hmm. Okay. Yeah, it seems pretty
then-
prominent. So it's just ringing, then maybe that's what
Yeah.
it is. Yeah.
Yeah, you can see it in the flow too.
Yeah, and I
right
think that may
beginning
be
there.
another
Yeah.
indication that the patient's still trying to inhale, right? The
It might
ventilator
be.
stopped giving flow, the patient's still inhaling, so the pressure tries to go below baseline,
Yeah.
and it's all screwed up.
Yeah. I don't
Yeah.
know about that. I think it's just noise. I see this with kids with low compliance
Yeah.
all the time,
Yep.
and the
Yep.
noise is even worse
Yep.
with those
That's
smaller
true.
tidal volumes.
Yeah, I think
But
so. And I think that part about low compliance is definitely an issue. I mean, it's still an artifact. Yeah, and I think that becomes an issue. And in fact, I've had severe enough that it actually causes a false trigger. Sometimes it reverberates so much it goes like just
Yeah, it
like
can.
slightly above the baseline.
Yep.
Rob's question in the chat, can you explain what clues we get from the high peak inspiratory flow to peak expiratory flow that made you think about resistance
so-
or continued breath?
My interpretation of that is you can see that the patient has a pretty modest or a small inspiratory effort, right? Because that little white line on the green line is pretty small. So the ventilator kicks in with a high pressure, and that pressure change from P to the inspiratory target pressure, that delta P is the driving pressure for inspiratory flow. So you take that pressure and divide by resistance and you get peak flow. On the other hand, the peak expiratory flow is the plateau pressure minus PEEP. And if this patient was passive, you'd see exactly the same peak inspiratory flow as peak expiratory flow. You don't see that here. So that means something else is happening. So what's happening is that driving pressure for expiratory flow is being offset by the patient's continued inspiratory effort. That's the way I would look at that. I can't think of any other explanation for that.
Oh, I like that explanation. Sherry asked, if the patient has PMUS during inspiration, how can you tell if the cycle is normal or early? Yeah, that's a good question. It depends on the transition from inspiration to expiration, right? So I think if you have if you have a early cycling, so the machine is cycling before the patient's ready to cycle, then you'll see an upward deflection in the expiratory waveform at the very beginning of it, suggesting that inspiration is still happening. So it'd be something like this, maybe.
Yeah, right. So if there's that which you see, that indicates that the inspiratory or the neural inspiratory time is longer than the ventilator inspiratory time, which is the definition of early cycle, right?
Right. Okay. I think let's move to the next one. Let's clean up my screen here. Apologies for my technical lack of savvy here. I've never used this program before today. All right. All right, so here is another waveform. and we'll give you some time, since the poll's not working, we'll give you some time and to interpret this. This is the case that I have, so I can talk about this one in great detail. But we'll give you about a minute or two, and then we'll ask to see if a fellow or somebody else wants to volunteer to walk us through this.
Any volunteers for this one?
Seem to have a paucity of fellows on the call, but I see a couple if anybody wants to take a stab at it.
I can volunteer.
Looks like Samid is in the chat.
Yeah. Hey, Matt, can you hear me? My mic has,
Yeah.
I'm having trouble with my mic, but yeah, I can volunteer for this one.
Awesome.
So the tag is VCCMVS. I think it's pretty straightforward in terms of the tag. The load, I think during inspiration, the load is fairly normal, although the short eye time would make me think it's elastic, but I think the respiratory rate and the ratio is high enough. So I would say there is normal load and inspiration, but expiratory load is definitely resistive. So I would say resistive based on the pressure waveform and the prolonged eye time. In terms of PV discordance, the patient is fairly passive. I mean, I think these are all machine triggered breaths, so difficult to say if the patient is triggering, but it doesn't seem to be any failed or false triggers that what I would expect. I mean, with the resistive load, I'm expecting this patient to have some obstructive disorder, but I don't see any failed triggers or whatnot. But inspiratory wise, again, very passive patient, appears to be paralyzed, no triggers, so no inspiratory work shifting at all. And similar for cycling, I think. I don't detect any discordance between neural and machine cycling. And expiratory wise, I think the patient is still not reaching baseline during that, but other than that, I don't see any active work being done by the patient. Again, seems very passive on the vent. So that will be my interpretation of that. The only other finding I would add is the expiratory limb. I don't see it quite reaching the baseline, and that's why the resistive load is something that's in my mind.
Great. Anything else that looks just kind of different than a normal waveform?
I mean, maybe in the inspirator, in the pressure waveform, if you kind of look at like it just dips down and then sort of has this long plateau.
Talking right here, right?
Yeah. And I was pointing with my pointer with the assumption that you can see it, so it's fairly mundane. And if you look at the expiratory phase on its own, I mean, it's not very exponential. It's like a more plateau than an exponential exhalation. So I would wonder what's going on during exhalation phase in the patient. Either is it if there's some problem with the ET tube, or some problem in the patient's airway or something. I mean, that will be something I would think, or something in the tubing, like maybe outside the ET tube, if there's something that's that's acting like a semi valve situation, that's slowly releasing the flow or something like that.
That's a good observation.
Yeah, that's
This is
fantastic.
the first time we've seen this particular situation, right, Matt?
Yeah. Yeah, so I'll talk you through the steps here, and then I'll tell you what this case was, because it was very
Honesty,
interesting.
I might have been like, I saw that once in the Bronx suite when we were trying to stent someone with extensive. So that sort of what reminds me of that, maybe something like occluding the area or something like that. But I'll be interesting to see what you find out in the ICU.
Yeah, no, I really liked your stepping through that. I think you hit on a lot of the important things. The tag is right. We made it a little easier. We left it up here. It's a VCCMBS. The load, I think, depends on the phase in this case. So we didn't really give you a good, this waveform looks, the pressure waveform, you're right, this is the passive patient. This is the paralyzed patient. The pressure waveform step up here looks fairly straight, but the peak pressure is pretty high for this volume. It doesn't tell us if it's resistive or elastic, but I'll tell you this is a patient with ARDS. So I think the inspiratory load was probably different than the expiratory load. The expiratory load, you're right, this is a resist. So there's no trigger issues. There's no work shifting. It's a passive patient, and the cycle appears to be, at least on the flow, normal, but here there's something odd happening. And there's no expiratory work, but you were right to mention that this looks kind of resistive here because it plateaus out. It doesn't continue to decay, and we have a 1 to 5 I to E ratio, and it still doesn't approach the baseline. So that's all remarkable for somebody that has an elevated resistive load, especially in expiration. And then, yeah, you notice here, so normally this waveform, I'll try to draw it the best I can with the pointer that I have, but it should come all the way back down to the peak baseline and look like that. And obviously it doesn't. So there is ongoing expiratory resistance in a way that doesn't look like something that would come from a patient. And you can see that the measured PEEP is 22, even though the set PEEP was only 16. Some other contextual information that may be helpful for you for this patient is this patient was, this was the best FiO2 that we were able to get for a couple days, and this person was on inhaled epoprostenol. So then you start to wonder, is there something clogging the expiratory circuit? So the first thing that comes to mind usually is do we need to look at the expiratory filter, especially somebody that's on an inhaled pulmonary vasodilator. And actually, I changed it out. I checked it myself. I actually even hooked up a BVM right to the expiratory valve or to expiratory filter, and there was no resistance to flow there. So the presumption actually was that there was a valve issue or a cassette issue within the ventilator itself. So we actually switched the entire ventilator, and this problem went away. So it's purely a mechanical issue rather than a patient issue. But it took some, the way that this presented was, I was called to bedside because the patient was becoming very hypoxemic. They were on 100%, temporarily before I got there and started playing with them. They kept giving them 100% breaths because they were desaturating down into the low 80s. The patient was still completely passive. They had not moved the patient. They had not adjusted anything. The other thing I noticed was the end tidal waveform, which if you know me, I'm like kind of an obsessive about end tidal, but the end tidal waveform was like a perfect peak like this. So there was the efficiency of CO2 removal was basically nil. So we were getting an end tidal number of 40, and on a blood gas, the end tidal was somewhere or the PCO2 was in the mid 70 range. So really discordant there, which tells you that our efficiency of ventilation had essentially gone to almost nothing. And again, it was completely corrected by changing the vent out. Rob,
This is very instructive. We have routinely been looking at the expiratory flow waveform to determine what the time constant is, right? And just by looking at that, it's a prolonged time constant. But the problem is you can't tell if the resistance is inside or outside of the lungs or both. And this is a very dramatic example of how you can make that distinction, because the airway pressure waveform during expiration is strictly a function of the expiratory flow through the expiratory side of the ventilator. And generally, if that's a low resistance system, then that flow has very little obstruction. You go right back down to PEEP and you're good to go. So when you see something like this, you know that there's an external resistance from somewhere from the endotracheal tube outward is causing this to happen and reflecting in the airway pressure.
Yeah, that's great. And Aman made a very similar point in the chat right now to say it's essentially the same thing. So yeah, this is something really interesting and unusual, but something you should keep an eye on, especially, expiratory filters tend to clog a little more quickly when somebody has an inhaled pulmonary vasodilator like epoprostenol. That wasn't the case in this instance, but it was something that definitely came to mind. Any other comments or thoughts?
It can happen sometimes with just giving aerosol bronchodilators. It can happen sometimes with HMEs, depending on where the pressure is being measured. Yeah, but it teaches you how to do systematic troubleshooting in a situation like this, and you got to do it quick. Patient can be in trouble really quickly. You might have to take them off and bag them until you figure it out.
Yeah, and we were almost at that point. I was doing everything I could not to do that because this patient was also COVID positive. So I was trying to limit the circuit disconnects as much as possible. So fortunately, we just went right to it looks so abnormal to me. I'm like, this is a mechanical issue. I'm just going to change the whole vent out. So I actually checked the expiratory filter after I had already changed the vent because I didn't want to play around with it. All right, so we'll move on to the next one. So yeah, so the next comment was interesting. The inhaled and exhaled tidal volumes match. Yeah, I think a lot of the air was getting back out. It was just slowly, inefficiently, and we were probably still missing some of the trapping there.
Yeah, if there's no leak, the inhaled has to match the exhale, or the patient will blow up.
Yeah, exactly. All right. Next one, take about a minute or two, look this over, and figure out who wants to volunteer for the next one. All right, Aman has volunteered, so whenever he's ready, we'll get started with this one.
All right, I can go.
Awesome.
All right, so the tag would be PCCMVS. It's obviously a pressure controlled breath. The flow is not controlled. I times looks constant. The pressure value looks constant. So for the load, so I would choose the middle breath to decide on that. There's some PMUS in the first and the third breaths. The middle breath during inspiration seems to be passive, also expiration. Now, this is something which I'm kind of stuck between choosing resistance versus elastance. If I look at the inspiration, it decays down to almost zero within the TI, which is maybe about a little more than a second. So that makes me lean more towards elastic load. However, during expiration, I don't think it totally comes back to baseline in like 1.5 seconds. So I'm not sure. I would probably do objective measurements here, but I would probably lean towards the resistive, looking at that expiratory flow. So PV discordance. So looking at the first and the third breath, there's PMUS right in the middle of the breath. So I would call this early trigger in looking at these two breaths. Classically described as reverse triggering. Inspiration, there's some work shifting in the first and the third breath. And the cycle, it would be early, just because there's reverse triggering. So technically this would be early cycle, but that's more of a manifestation of early triggering in the first and third breath. And expiratory is mostly passive, so I don't see any major significant expiratory work. I would just finish by commenting that I would want to know like what the RAS is for this patient, but I know there's like different causes of early triggering, and reverse triggering is one of the classic ones described in the literature. So if this is a repeated pattern, so I see one reverse trigger in the second passive breath. So if this is a 2-to-1, you know, like every other breath reverse triggering pattern, then this might actually be the classic reverse triggering in a deeply sedated patient, as described in the literature.
Great
Very good.
analysis. Yeah, I agree with everything you said. I think it is having one breath to work with here. It is a little bit difficult to discern the predominant load and the passive breath. Yeah, this arrow does make me think of resistant, higher resistive load. A little bit hard to say without more information, like you mentioned. The major issue here is the one that you pointed out, is basically we have what looks like a machine triggered breath followed by a patient's diaphragm being triggered dysynchronously to that right about here. So PMUS is kicking in right around here. Which makes the cycle time from the ventilator appear short, because our patient got a late start in this breath. And the same morphology happens over here where the PMUS is happening sort of halfway into the breath. So I think this is a good pattern for reverse triggering. And what we're seeing here, since we're talking about expiratory waveforms, what we're seeing here is continued inhalation during the first part of exhalation. So that tells you there's a cycle dysynchrony. It doesn't tell you what it's from. But it tells you the machine cycled before the patient was ready to be done with the breath, just because of the sort of phase delay of the PMUS compared to when the vent fired.
Yeah, it's interesting that you can have multiple synchrony problems, right? One causing another one.
Yeah, absolutely.
This is a unique graphic because, as you pointed out, the middle breath is passive. And I think it very clearly shows in this case that the expiratory resistance is higher than the inspiratory resistance. You pretty much have to assume that the compliance is the same. But clearly the time constant is longer during exhalation. The only way that can happen is there's secretions happening on exhalation, or maybe airways are collapsing. I don't know what kind of patient this is, but some kind of ball valving effect, but clearly in 2 different time constants.
Yeah, for sure. So a couple things that popped up in the chat. Would reducing the respiratory rate help the situation? Probably not. If you want to see if the patient's triggering the breaths or not, because sometimes, sometimes work shifting can look like this if the patient realizes, sort of neurally feels the breath is starting to end and then they sort of take over. So something you could do is you could switch them to pressure support and see if they actually trigger any breaths or not. And sometimes in somebody like this, you'll find that they don't. And then the other comment is reverse triggering doubles the tidal volume, and that would be true if it triggered a second breath. In this case, we're just seeing an inspiratory effort that didn't actually trigger a second breath, but sometimes you will see it generate a second breath, and it'll look like that, and you'll say, oh, they're double triggering, which again is a pattern. It doesn't tell you why it's happening, and
Yeah,
then it's up to you to
I
decide.
think there's a valid point there, Matt. It's not that if you look at the volume waveform, right? Obviously, the one where there's reverse triggering has a much larger tidal volume than the passive breath, almost
Yeah.
double, probably is double, right? And the simple reason for that is the passive breath only has P vent, so that's all the volume
Right.
you're going to get. But in the reverse trigger breath, or the early trigger breath, you get P vent first, and then you get PMUS on top of that, and that's why you have a much larger tidal volume. So you can make the argument that, in this case at least, the early triggering is almost as bad as double triggering.
Yeah, right. Because since we're in pressure control, that definitely makes sense. In volume,
I'm sure that tidal volume is too big. It's probably around
Yeah.
600, right?
Yeah,
So if you could do something to get rid of it, it would probably be safer for the patient.
for sure. And in this case, as Aman pointed out, sometimes paradoxically the answer is to decrease the sedation rather than to try to increase it, because there's a thought that maybe this one potential etiology for this problem is that it's due to excess sedation causing the problem, causing the vent and the diaphragm to be out of sync.
Mm.
All right. Another question: is there a leak since the volume time graph resets? I think we just didn't finish exhalation there.
Right, that's all that was.
Yeah.
The next breath was scheduled to happen, and the ventilator just resets the graph.
Yeah.
But it does, yeah, you're right, it does look like a leak, but in this situation, that's not what's happening.
And then finally, Ariel, the reverse trigger effort should overcome P-plat from the first breath in order to trigger the vent, right? I think it just has to overcome, it just has to meet the flow, or it has to meet the trigger sensitivity to trigger this
Right.
the next breath.
Right. Yeah, I think, yeah, I think that's probably true. The inspiratory, the P mus would have to be bigger than P plat in order to get the flow to go through zero. So that's probably a true statement.
All right, great.
Wouldn't
Great
that
comment.
only work if you're in a flow trigger mode? Like if you're pressure triggering, you'd have to bring down the overall pressure down to PEEP and below.
Yeah, which you can't do unless the flow goes through zero.
Yeah.
Right.
Either
So
way
that
you
would
look at
only
it.
happen if you're flow triggering. At that point, you need to generate a differential to double trigger, but then it has to be outside the refractory window
Yeah,
after the
yeah.
breath.
A few milliseconds beyond that. That's
Yeah.
all true. Yeah.
Great. I probably got time to go through, probably one more. I'm going the wrong way. All right, here's another one. Give you about a minute or so to look at it, and we'll see if anybody wants to take a stab at it.
You happen to know what ventilator that is? Is that a Hamilton?
You know, I'm not sure. Rashik, one of our former fellows, sent it to us.
Yeah, it's not
not
one of
sure.
our vents. It's
Right.
it may be a Draeger, Savina, or something like that, but I don't recognize the waveform.
Yeah, me either.
This is an interesting one.
Anybody feeling brave? All right, Steve Fox, whenever you're ready.
Yeah, so I'm stumped, but I'll still volunteer. But anyway, so in terms of the tag, well, it's CMV and S, but I'm trying to decide if it's PC or VC. I mean, the volume waveform, of course, the first thing to look for. It doesn't look like totally perfectly symmetric with a descending ramp, but it's pretty close. So I mean, it could be volume control with a descending ramp, or it could be pressure control. I'm finding it a little bit hard to tell here just because of how symmetric the volume, the flow waveform is looking. If I had to guess, I'll go with pressure control, but I don't know on this ventilator again, it could be volume control. So what's the load? And that, I guess, we'll just be looking at the correspondence of the pressure waveform and the flow waveform. And the way that the pressure waveform is just flat at the top, and I guess the expiratory, well, so the expiratory waveform is a little bit funny too, and this is part of why I think this is stumping me, especially the expiratory flow waveform, because it starts to go down, and then all of a sudden it just kind of drops off completely. So it's almost as if something is limiting the expiratory flow, and then all of a sudden, you know, well, I'm trying to think how else to work. Okay, so it's as if there is expiratory flow for a while, and then all of a sudden the expiratory flow stops or slows down, and that's you know, it also reflected on this volume waveform, where it goes down steeply and then all of a sudden goes down not steeply. So anyway, this is the part that is stumping me here. So the moral of the story of what the load is. Let's see. I think I'd be inclined to go with elastic, but it's a little bit, you know, hard even to say. And then in terms of if there's PMUS, I mean, it's an irregular shape of waveform, which then leads me to think PMUS, but at the same time, it's the same in all the breaths. And it just, so I don't think it is PMUS. I think the patient's probably passive and there's just something funny happening here that I don't know what it is. Any PV discordance, trigger, and again, you know, without even really seeing for sure if there is PMUS, how do you tell what's happening with the trigger, you know, in terms of normal, I guess in terms of cycling, similarly, it's hard to see any evidence of early or late cycling here. And inspiration, no evidence of work shifting. And expiration, I don't see much in terms of expiratory work. So anyway, it is a little bit of a stumper. I think I see a comment in the chat, which I kind of like actually, that maybe the airways collapse during expiration, toward the end of expiration, maybe a COPD sort of a phenomenon, I don't know.
So a couple of things. Thank you, Steve, for that analysis. I think there's a lot that you covered there that's useful. You're right. It's a little hard to tell the tag because of the way that the pressure waveform looks, and you can't really tell you know, how straight this line is. It's probably PC just from the looks of things. The load, you know, so you notice that there's this abnormality in at the end of exhalation here before it turns to baseline. But this is such a wide area right here that really looks like a high resistive load. And then the other thing that we see here that we kind of notice, and yeah, I agree. Otherwise, this patient looks pretty darn passive. The other thing is, you know, this part of the waveform here is compared to what it might look like and what it does look like. Again, we're dealing with something that really doesn't, it would be hard to explain with human physiology for the ventilator to see the pressure waveform decrement in this way. But then you see it really kind of, unlike the one that I showed from my case, this one like snaps back all of a sudden and then kind of returns to normal. So does that give you any hints about what might be going on here?
Is this a lung transplant patient or something different with their lungs with the differential resistance on two sides?
As far as I know, there's nothing particularly interesting about the patient.
Because the volume time waveform is also weird. You have sort of a reduction in the tidal volume coming down, and then you have it's almost like an asymptote after that, even after the flow has hit baseline. So I wonder if there's like a nebulizer or something turned on, or there's just something going on there that's contributing to the tidal volume persisting after flow is returned to normal in the ventilator circuit inside the ventilator.
Yeah, no, that's a great point. Before I give the reveal, Rob, anything you want to say about this?
Just a couple of things. As you pointed out, if the airway pressure doesn't drop down to baseline, as like we saw previously, that means there's something from the airway out towards the ventilator that's causing that. That's back pressure on exhalation, not happening in the lungs. The other thing is, you notice that there's an orange line that says peak trach. That's a clue that, you know why that's there? Anybody know?
They have a proximal sensor.
It's ATC on.
Yeah, it's automatic tube compensation, airway resistance compensation. So the ventilators, you type in what the size of the airway is, and the ventilator estimates the resistance, and and gives you a boost in inspiratory pressure, which you can see is a little hump, in order to overcome the peak inspiratory, inspiratory resistance during the peak flow. So that's also another clue that this is pressure control, because you don't do that in volume control.
Great. And Ariel pointed out, usually Hamilton vents display that red line in adaptive pressure or ventilation, so PCCMBA, not in PCCMBS. So that's another hint to what's going on here.
Interesting.
Yeah. And then remember, if we are doing ATC, ATC is automatic tube compensation, and that's the control, or the targeting scheme for that is a servo targeting, just kind of like similar but different from PAV and NAVA. So it's same targeting scheme, but different.
It's layered
technology.
on top of the set point, so it's both set point and servo.
Right. So in this case, as I don't know who ML is in the chat, but ML gets a gold star because it is an expiratory valve malfunction was the cause of this issue. So you can see it kind of maybe it was hanging half open for a second, then it snapped shut, and that's why you had that resistance that was extrinsic to the patient. But then sort of resolved. So a lot of interesting technological issues we're uncovering with our examination of the expiration waveforms here. It's 2:51. We might be able to do one more quickly.
On some ventilators, the ATC function is active during exhalation as well, right?
That's correct. You can on some you can set one or the other.
Okay.
Yep.
Great. That was
Got a question. Since I'm not familiar with this particular event, are we talking about the exhalation valve? Is this a single limb circuit with an exhalation valve, a mushroom valve, or are we talking about a ventilator internal valve malfunctioning?
Internal.
Yeah, if this is a Hamilton, they'll be all internal valves.
Is it a G5 or?
I don't know. Ariel, do you recognize this vent?
Yeah, I don't know, to be honest with you.
I don't know. It's unfamiliar to me.
Yeah.
So essentially we're saying that the valve generates a bit of resistance and then it just pops open, releasing the resistance suddenly.
Looks like it.
Yeah.
It's
That's what it
sticking
looks like.
closed for some reason. Yeah.
Okay.
I was gonna ask about the airway resistance though. Like besides the malfunction, it looks like even on inspiration, I mean the peak inspiratory flow is only what, like 30, 40 liters per minute. So I'm imagining the patient also has a high airway resistance. Is that
Yeah, they
correct?
very well might.
Yeah. That's pretty low peak flow, that's for sure.
Yeah. Yeah. That's a good point.
And that's even with ATC. You know, ATC
Right.
should boost that peak inspiratory flow. So this patient probably does have an airway resistance problem on top of everything else.
Right.
On top of having a vent resistant problem.
So Matt, just to clarify, so if I'm hearing this correctly, so initially there is some resistance offered by the expiratory valve. That's why you have that gradual, decay of airway pressure. But then when it reaches the set PEEP, then that's when the valve shuts down, like closes down totally.
Well,
I'm
it
not
opens
sure if
up
that's-
totally.
Yeah, it opens. I'm not sure what's the impetus for it opening. I don't know if it I'm not sure about. But certainly
Just curious, because at that point the flow actually decays down to zero, the expiratory flow. I mean, if there's low resistance, I wonder why it would decay down to zero if the valve's fully open at this point.
Well, it's not exactly zero, because otherwise the volume would have been down to zero too. I think it's just a scale factor that you can't see. It's a very low flow. It's not zero because you're still exhaling.
Yeah, that's a good point.
I was just wondering if the resistance is in the circuit is coming down, why is the flow expiratory flow decaying as opposed to for a same pressure differential? Because we're at almost at the same pressure differential. The flow is decaying then
That's why I was asking about the ATC. If ATC is active in expiration, they may have a threshold that at a certain flow, the ATC backs off and you don't have any assistance from the servo mechanism. I don't know the answer to that, but if the ATC cuts off at a certain flow threshold, that might explain the abrupt
That's a good point, man.
cessation.
Yeah. Yeah, I'm not sure to be honest with you, but that sounds like a plausible explanation. So now it's 2:55, so I think we'll probably just call it good here. I'm gonna put up the last couple slides for CME and everything so everyone can see those. So here's the CME slide. So if you're a CCF employee, go ahead and snap the QR code. The CME code is in the slide, and collect your credits. We really appreciate everyone joining us today. We had about 30 people with us, which was great. Some great comments. If you have, sorry, going the wrong way again. If you have comments or waveforms that you want us to see, Eduardo, Rob, and I are all on Twitter, or you could email Eduardo directly. He will be back from vacation for next time. So thanks to everyone for joining us, and thanks for coping with my adjustment to this platform. I appreciate it.
Yeah, and hope to see you guys on the Virgo meeting in a few minutes.
Awesome.